Okay, I'm going to go ahead and begin with some introductions. I want to thank everybody for being here today. We have always had such a wonderful relationship with UTHealth Houston Neuroscience, and it's been a privilege to be able to work with them through, again, 2022, to be able to offer you all medical topics that are important to you to learn and to grow and to be in good health. So today, as always, we have our topic for the month of November. So I'm going to ask Elise Pratt to go ahead and introduce our speaker for today. Thank you.
Thank you, Elena. Hi there. So today we've got Dr. Verma, who will be talking about restless leg syndrome. And Dr. Verma is a neurologist and sleep medicine specialist here at UTHealth Houston Neurosciences. Just a bit about us. We're a large multidisciplinary group of neurosurgeons, neurologists, pain management specialists, neurocritical care specialists, and sleep medicine specialists, and lots more stuff here at the Texas Medical Center. We have over 150 providers and locations around the city in addition to ours here at the TMC. Dr. Verma will talk for a bit and tell you about restless leg syndrome. And then at the end, we will answer questions. So if you can just put your questions in the chat, we will keep track of those and we'll ask them at the very end for Dr. Verma to answer. And Dr. Verma, go ahead.
Oh, thanks, Elena and Elise for that lovely introduction. So the topic for today is restless leg syndrome. So over the course of the next 30 to 40 minutes or so, I will go over several different topics related to restless leg syndrome. Firstly, starting out with the clinical features. I will talk about the major risk factors for precipitation of restless leg syndrome, genetics, the prevalence of restless legs, and at the end, talk about how to evaluate and then talk about treatments associated for restless leg syndrome. So restless leg syndrome is a clinical diagnosis. You do not need a sleep study to diagnose restless leg syndrome. The four cardinal features that constitute the restless leg syndrome is having an urge to move, and many people describe this urge as in many different ways, whether it's an unpleasant sensation, some people describe this as pain, and these sensations begin or worsen during periods of inactivity. They're primarily happening in the evenings or at night, and this sensation is relieved transiently by movement. So the mnemonic that is commonly used for restless legs is inactivity, IDLE. I stands for inactivity, which precipitates the discomfort primarily in the evenings, and it's predominantly seen in the lower extremities, although some patients with advanced RLS can also have these symptoms in their arms as well. Some of the supporting clinical features for restless leg syndrome is usually there is some sort of a family history of restless leg syndrome, but not always necessary. PSG stands for polysomnogram. So if a patient has a sleep study, many of patients that have restless leg syndrome can have coexisting PLMs that are periodic leg movements. Many of these patients also complain of a sleep disturbance, whether it's fragmented sleep, non-refreshing sleep. And one of the things that supports the diagnosis is if a patient is started on treatment with dopaminergic agonists, which I will go through at the end of the presentation, that also supports the diagnosis of restless leg syndrome. Some of the other common clinical features are, as I said, these symptoms tend to peak late evening or sometimes can even wake patients out of their sleep in the middle of the night. These symptoms can also cause sleep onset insomnia where patients are having trouble falling asleep. As I said, they also can describe these symptoms as pain, and pain is present in approximately 20% of people who experience symptoms of restless leg syndrome. So the demographic features, it is rather quite common. It's seen in 3 to 15% of general population, and the prevalence increases as we age. And there is a bidirectional type of relationship, primarily with restless legs and periodic limb movements. So 70 to 90% of patients that have restless leg syndrome can have coexisting periodic leg movements. However, only 1/3 of the patients that have PLMs or periodic leg movements will have symptoms of restless legs. So the bidirectional is more consistent with the PLMs, with restless legs and PLMs rather than the other way around. If you look at all the different sleep disorders, restless legs has the same prevalence as insomnia, which tells me that it is quite prevalent in the general population. There are other sleep disorders like central sleep apnea, chronic narcolepsy that are not as common as restless legs, but restless leg syndrome is quite common in general population. The mean age of onset is around 34 years plus minus 20 years, and usually it has two peaks. One is early, like in middle, between teenage years, early adulthood, and later on in life. In adults, females have a higher prevalence than in males. However, in children, restless leg syndrome in children has equal predominance in both males and females. Again, this is showing the female predominance in adult restless leg syndrome with no gender difference in childhood restless leg syndrome. The symptoms can happen at any age, like I said, but it has like a bimodal peak, one between the age of 11 to 20 and later on in middle to older adults. The remission of symptoms is supposed to be more milder in milder cases of RLS and more likely to happen in those cases, and also in secondary RLS rather than in primary RLS. And I'll go over this classification in just a second. So this slide actually gives us that classification based on when the symptoms start. So patients can have primary restless leg syndrome or secondary restless legs, and primary restless legs can be early onset or late onset. As the name suggests, early onset restless leg syndrome primarily starts in patients before the age of 35 to 45. It differs from the secondary restless legs by having a more gradual onset, and patients that have early onset restless leg syndrome tend to have a strong family history. And this slide here actually gives us the nice differentiation between the two types of restless leg syndrome. As I have mentioned, patients with primary restless legs have a rather milder symptomatology. The progression of symptoms is not as rapid, and however, the reversibility is not as easy in primary restless legs versus secondary restless leg syndrome. In females, as in with adult restless legs, females have a higher prevalence rates, and pregnancy definitely exacerbates that. There are other sleep disorders that can have restless leg syndrome coexist with them, and the common ones are narcolepsy and REM sleep behavior disorder, which is also called RBD. There are several medical disorders that can have secondary RLS symptoms, develop diabetes. Most of these patients have associated neuropathy that can also worsen symptoms of restless legs, end-stage renal disease, iron deficiency anemia. As you can see, there are several other medical disorders that serve as a major risk factor for development of restless leg syndrome. Neurological disorders like multiple sclerosis, Parkinson's disease, different types of neuropathies, different types of spinocerebellar atrophies or strokes can all be a risk factor for development of symptoms of restless leg syndrome, especially in adults that are more older. Different types of mood disorders like depression, anxiety disorder can also have restless leg syndrome that coexist. And many of the patients that are on treatments for mood disorders with several different mood stabilizing medications can in by itself precipitate restless leg syndrome. There are patients that have gastric bypass surgeries with different types of malnutrition or absorption syndromes with various types of anemia that can also develop the symptoms of restless leg syndrome. I want to focus a little bit on how restless leg syndrome in women presents and also in a common medical condition, which is end-stage renal disease. So RLS in women can cause significant sleep disruption primarily during pregnancy. I see a lot of patients that get referred from OBGYNs, primary care physicians, where patients have never had a family history or prior symptoms of restless legs, where they only develop this during pregnancy. And most of it is due to volume shifts that happen with pregnancy-related anemia that can precipitate these symptoms. And if seen during pregnancy, it is most commonly seen during the 3rd trimester, and usually these symptoms get better after the delivery of the baby. Patients who have restless leg syndrome during pregnancy can also present with the family history, have a prior history of restless leg syndrome in the past, or prior history of restless leg syndrome during previous pregnancies. And having a prior history of anemia with low hemoglobin definitely will increase their risk of developing these symptoms while pregnant. In end-stage renal disease, again, because of the uremia, because of electrolyte imbalance that happens in patients with end-stage renal disease, restless leg syndrome is quite common. And many of these patients cannot lie still or even sit still to complete their dialysis treatments if the symptoms are very worse. And unfortunately, the treatment response in this patient population to dopaminergic agents might be less compared to the general population. And these symptoms might improve after renal replacement therapy or after renal transplantation. And many of these patients, even though they're on traditional treatments for restless legs, they have to have the treatment tailored as their renal clearance is low. So the medications have to be more tailored to their renal dosing and their dialysis. Anytime I see a patient that has restless leg syndrome, the first thing I want to see is to look at their list of medications. It is very commonly overlooked, but many medications can precipitate symptoms of restless leg syndrome, and most of these medications also precipitate periodic leg movements while asleep. Some of the common antidepressant medications, they're very notorious for precipitating symptoms of restless legs, and PLMs, over-the-counter medications like Benadryl, diphenhydramine, and anti-nausea medications, Reglan, which is metoclopramide. All these medications are definitely serving as a major risk factor for development of symptoms of restless legs and or periodic leg movements. So, touching briefly upon the pathophysiology, what causes these symptoms and why are some patients having developed these symptoms versus others who do not? So there is a abnormal dopamine synthesis, and iron plays a very important role in that. In patients who have symptoms of restless legs, there's decrease in the cerebrospinal fluid dopaminergic levels. And iron metabolism is very closely linked to the development of symptoms of restless legs. The reason for that is ferritin is a cofactor for this tyrosine hydroxylase, which serves as a rate limiting step for dopamine synthesis. So even if patients have normal hemoglobin and hematocrit, but if they do not have the ferritin that transports the iron to the regions of the brain that make the chemical dopamine, then patients can have symptoms of restless legs, because restless leg syndrome is primarily because of a hypodopaminergic state, that is decreased dopamine levels in the brain and in the CSF. Several genetic factors have been linked to patients who have restless leg syndrome, primarily patients who have primary restless legs. The close chromosome connections that have been made are this BD9 and MEIS1 gene. And you can see that the chromosomes that they are linked to, even periodic limb movement disorder, patients who have that also have some higher prevalence with that chromosomal single nucleotide polymorphisms that happen. So what causes, we talked about the causes of restless leg syndrome, but what are the consequences of restless legs and why is this important to treat the syndrome? Patient can present with insomnia, like I mentioned. It can be sleep onset insomnia or sleep maintenance insomnia. And patients experience severe sleep fragmentation, causing symptoms of non-refreshing sleep, daytime fatigue, excessive daytime sleepiness, difficulty concentrating, difficulty going through their daily routine because of this uneasy feeling. And over time, lack of adequate quantity or good quality sleep can cause cognitive impairment, decreased mood, behavioral problems, and decreased overall quality of life. With the awakenings and arousals that the syndrome brings, either just from RLS or from the periodic limb movements, these patients are known to have a higher risk of hypertension, coronary artery disease, overall, cardiovascular disease, and even impair glucose metabolism, leading to a metabolic syndrome in some patients. So where do we start and how do we diagnose this and what are the steps that we usually have to take? So when I'm seeing a patient, obviously the history is very important. Family history is important. The neurological exam most of the time is normal, except in some patients who might have secondary restless legs with neuropathy. Then you see that there is decreased reflexes, decreased sensation in the lower extremities. Then in the lab work, usually we check basic kidney function tests, liver function tests, basic hemoglobin, hematocrit. I always look for these elaborate iron panels, primarily serum ferritin levels, as serum ferritin plays an important role in the synthesis of dopamine. There are several different restless leg syndrome questionnaires that can be given out to patients to see how severe their symptoms are. And one of the such rating scales is the RLS rating scale, which scores a maximum score of 40. Each question, as shown above, is rated from 0 to 4. This can tell you whether the patient has mild, moderate, or severe restless leg syndrome. Many a times, you do not need to give out the rating scale, just the history, the frequency of symptoms, how many nights the patient is having the symptoms will help you categorize whether the patient is experiencing moderate or severe restless leg syndrome. Like I said, since this restless leg syndrome is a clinical diagnosis, you do not need a polysomnography or a sleep study to establish the diagnosis. The polysomnography is mainly indicated if you're not sure about the diagnosis and the sleep disruption is persisting despite the treatment of the symptoms. And if you feel like the severity of sleep disruption cannot be explained by restless leg syndrome alone, i.e. if you're thinking that there might be another coexisting sleep disorder that you need to diagnose, certainly in-lab sleep studies would be very helpful. A trial of dopaminergic treatment, if you start the patient on a treatment trial, see the patient back in a few weeks and they have improvement in symptoms, that also supports the diagnosis of restless leg syndrome. If I'm reviewing a sleep study, the things that I'm looking for are patients that have sleep disruption. On a sleep study, you will see that their sleep onset latency, SOL, that means the time it takes for them to fall asleep, is increased. And they have multiple awakenings throughout the night, causing them to have decreased sleep efficiency and decreased total sleep time. Many of these patients, since periodic limb movements coexist with restless legs, you will see that those features on a sleep study as well. According to International Classification of Sleep Disorders, that's the most updated diagnostic criteria. In order to diagnose a patient with restless leg syndrome, they have to have symptoms in A and B, the associate features. Like I said, the 4 cardinal symptoms are patients experience an urge to move the legs due to an unpleasant sensation that begins or worsens during rest or inactivity, primarily occurs during the night or in the evening hours, and it is relieved or partially or totally relieved by movement. then these symptoms have to cause an associated sleep disturbance or sleep disorder or impaired functioning. And that's where if you have these symptoms under the category A, along with the sleep disruption, then the diagnosis of restless leg syndrome is established. There are different conditions in sleep that can mimic restless legs, like nocturnal leg cramps. So when obtaining a history, it is very important to ask what they mean by the unpleasant sensation. And I usually have the patient describe in his or her own words as to what that means. There are several different medical disorders like peripheral neuropathy, restlessness from akathisia, claudication, which is a vascular issue, can all mimic symptoms of restless legs. There are other disorders where patients say that it's a habit, I move or jerk my legs or my legs twitch. So that's not restless legs. So you have to meet that 4 cardinal symptoms along with an impaired functioning or sleep disturbance associated with those symptoms. So let's talk a little bit about how do we go about choosing the type of medication and what is the right treatment for restless legs. So before we dive into the pharmacological treatment, I always ask patients about any known precipitating factors and what have they been doing to relieve the sensation and how long have they had these symptoms. So trying to find and eliminate the precipitating factors, if they're taking any over-the-counter medications like antihistamines, that history is very important. Eliciting a prior history of anemia, family history is important because, like I said, the serum ferritin levels have to be checked and have to be optimized in order for the treatment to be consistently effective. The most common agents that are used to treat restless leg syndrome are dopamine agonists. If you recall, restless leg syndrome is a hypodopaminergic state. So there is decreased levels of dopamine. So the treatment is to augment dopamine. There are different forms of dopamine that are available. Levodopa, it has a very short half-life and is generally not recommended because of the short half-life and also for the higher risk of rebound and augmentation, which I'll talk about in the next couple of slides. Pramipexole or Mirapex, ropinirole or Requip are some of the common agents that are usually started by primary care physicians and or sleep specialists. Each one has its own pros and cons. As you can see, pramipexole is cleared renally. So if a patient is on dialysis or has renal impairment, it might be best to choose the other dopamine agonists like Requip. Pramipexole has a longer half-life compared to ropinirole, which has a faster onset of action. Rotigotine is a Neupro patch, and there are some patients that need a 24-hour coverage or delivery of the medication, so the patch serves that better, and it also helps alleviate some of the adverse side effects of augmentation and rebound, which I'll touch upon in just a second. The common adverse effects with dopamine agonists is nausea, sleep attacks. Patients say as they go higher up on the doses, they're having this unexplained excessive daytime sleepiness. Higher doses in the Parkinson's disease category can develop compulsive behavior, and these treatments are not indicated in children and or in pregnant women. So one of the main issues that comes up with treatment with dopamine agonists is this phenomenon called augmentation or rebound. Previously, before, when we did not have a whole lot of different treatment options, levodopa, even Mirapex, the pramipexole, ropinirole were commonly used. And as we increase the dose of these medications, you start patient, the classic history is that the medication worked great for the first 2 months, then I increased the dose. Now I'm starting to have to take the medication earlier and earlier in the evenings. I'm having symptoms even, experience symptoms even in my arms. So that augmentation and rebound is a big issue associated with dopamine agonists. I usually try to avoid the dopamine route because we have other options at this time because of that reason of augmentation and rebound. And if I see that there is a patient that has already been on higher doses and is developing this augmentation rebound phenomena, I usually try to switch them to a longer acting dopamine agonist and try to taper off the agent that's causing issues or split the dose. So every patient is different based on their family history, whether it's a primary RLS, secondary RLS. We obviously have to screen for other conditions that might be making restless leg syndrome worse, and also taper off the medications that might actually might be causing the augmentation and rebound. The other treatment options that we currently have are gabapentin anacarbol medication. The brand name is called Horizon, which works very well in patients that have moderate to severe restless leg syndrome. Pregabalin, carbamazepine, all these medications tend to avoid the dopamine route and will give the same symptomatic benefit for patients. Patients that have severe symptoms refractory to other treatments might need opioid agents like codeine, oxycodone to help relieve the symptoms. Benzodiazepines like clonazepam will be very effective, especially if they have insomnia associated with restless leg syndrome as well. I want to talk a little bit about restless leg syndrome in children and talk about periodic limb movements in sleep and periodic limb movement disorder. The prevalence of restless leg syndrome in children is 1 to 5% in the general population. Most of the treatments that are available are not FDA-approved treatments for RLS in children and in adolescents. So the same diagnostic criteria applies for children, but the associated features are that the child describes a sort of leg discomfort in his or her own words. And you have to have 2 or more of the following. Either the child or the parent describes that the patient is having a sleep disturbance, there's a biological parent or a sibling that has diagnosis of definitive restless leg syndrome. And if the child has had a sleep study, you will see that the periodic limb movement index is greater than 5 per hour during the sleep study. And these features should not be explained by another sleep disorder. So then the diagnosis of restless leg syndrome is established in that child. So periodic limb movements during sleep, as I've mentioned before, 80 or 70 to 90% of patients with restless legs can have coexisting periodic limb movement disorder or periodic limb movements during sleep, which is only seen or picked up on a sleep study. Not everyone that has periodic limb movements is diagnosed as having periodic limb movement disorder. So like I said, 70 to 90% of patients that have restless legs can have coexisting periodic limb movements. There's no predominance in females when compared to males for PLMs during sleep. That's a difference than what restless leg syndrome presents more in females in adults. And many of the risk factors for restless leg syndrome are pretty similar and serve as the same risk factors for periodic limb movements. And they're associated with many sleep disorders. RLS, as I mentioned, is the most common disorder associated with periodic limb movements during sleep. So in order to diagnose periodic limb movements, you have to, these are only picked up on a sleep study. The only history that we might have is a bed partner saying that someone's legs are shaking or they're moving their legs throughout the night. They're primarily seen in lighter stages of sleep, not as common in deep sleep or REM sleep. And there might be a night-to-night variability in the frequency and or severity of these periodic leg movements. These periodic limb movements can also cause arousals, and when they cause PLM arousals, that's when patients have autonomic symptoms and also can have increased risk of hypertension. These periodic limb movements are also seen in other sleep disorders like narcolepsy and in REM sleep behavior disorder. So periodic limb movements is different than periodic limb movement disorder in the fact that these periodic limb movements should, and if they're causing a sleep disturbance or impaired functioning, then the diagnosis of periodic limb movement disorder is determined. Symptomatic periodic limb movements need to have a sleep disturbance or symptoms of excessive daytime sleepiness in order to be called as a periodic limb movement disorder. They have the similar mechanisms and many risk factors common with restless leg syndrome patients, and they're quite commonly seen in other sleep disorders like obstructive sleep apnea, narcolepsy, and REM sleep behavior disorder. The consequence of periodic limb movement disorder is pretty much the same as in restless legs, where patients have increased sleep fragmentation, non-refreshing sleep, daytime fatigue, and the arousals that happen from the periodic limb movement disorder can increase the risk of hypertension, cardiovascular risk factors, increasing mortality, and stroke. And the treatment for periodic limb movement disorder is very similar to restless leg syndrome. So to summarize, the common agents that are used to treat restless leg syndrome and periodic limb movement disorder include dopaminergic, agents. We also have gabapentin-like medications, pregabalin, gabapentin anacarbal. Opioids are primarily used in severe refractory patients that are non-responsive to other traditional restless leg syndrome treatments. And benzodiazepines work well as a secondary treatment for restless legs if patient has coexisting insomnia and or REM sleep behavior disorder. But it is very important to see what underlying medications the patients are taking so that we can optimize their treatment regimen and avoid different treatments based on if they are in the pediatric age versus if the patient is pregnant or not. With that, I am at the last slide. I will take any questions, and the phone number for our clinic appointments, I listed that on the last slide.
Excellent. Thank you, Dr. Verma. Everybody, please put your questions in that chat window, and we will answer those as we get them. I have a couple here already. One question is, what about diet? Is there anything I should change in my diet?
Yes, so in diet, there are several dietary precipitating factors. One of the big precipitating factors is caffeine. So if some people are more sensitive to caffeine than others, but there is a strong correlation of caffeine precipitating symptoms of restless legs. Even if they have switched over to decaf, that helps some, but eliminating caffeine definitely is one of the things that I would recommend. The other thing is alcohol. Some patients say that alcohol does precipitate, and depending on red wine versus, different types of alcoholic beverages, it all depends on what someone's threshold is, but caffeine and alcohol are the main dietary precipitating factors for restless legs and or periodic leg movements.
Okay, makes sense. Another question, are there any leg exercises that help?
The movement helps. Yes, that's one of the things. So there's no specific leg exercises, but stretching, walking, massaging the legs or the areas of the body where the symptoms are occurring definitely helps, but there's no specific exercise that is tailored to treat restless leg syndrome.
Okay. My husband is on CPAP, so did his sleep study, diagnosed for PLM, and also, okay, let me read that again. My husband is on CPAP. Did his sleep study diagnose it for PLM? And also, does using CPAP help him with PLM?
So yes, CPAP obviously is treating the obstructive sleep apnea, but but the CPAP can also indirectly help by stabilizing the arousals, treating the apneas, and and during the CPAP studies, usually the CPAP pressures are titrated a little higher to see if that can alleviate, but that's not the direct treatment for periodic leg movements. But any type of sleep stabilization definitely helps with decreasing the arousals, especially if the periodically movements are causing arousals during the sleep study.
Okay, excellent. I'm waiting for any more questions, so I'm going to give us a second for people to post any more. I'll also put our contact info in the chat, just if you want to cut and paste it or copy it down. We are here in the Texas Medical Center. That's where Dr. Verma's clinic is. And if you give us a call, we can schedule you with her. And we've also got a raised hand. Elena, I don't think we can use that. So I think
that's okay. Let me see what we can do here. Let me unmute that person. Thank you for noticing that.
Yes, thank you.
Okay, allow to talk. Okay, the person that has raised their hand, I did open it up where you can ask your question if you want to, if you just unmute.
I struggle with insomnia and RLS since age 30. I'm now 70. I take pramipexole and it works. Please state again the likelihood that pramipexole will stop aiding me at a certain point. This is a fear I have, is that it works so well. I'm afraid it won't someday.
That's a question I might not be able to answer because I can't predict what might happen. The fact that you have been on pramipexole for almost 40 years and it's still working, it's reassuring that it might continue to work. It all depends on what dose you're on, what other medications you're on, what your other general medical health is. So without knowing all that, it would be hard for me to give a straightforward answer to your question.
Okay, thank you.
Okay, and I know we had a few YMCA members at one of our actual locations down at Trotter. So if any of y'all have questions, I've also added the email address here over in the chat. Feel free to send an email. Those go to me and several other people to help schedule patients and answer questions. But with that, I don't have any other questions in the chat. So thank you, Dr. Verma, and I'll hand it back over to Elena.
Yes. Thank you so very much. And for those of you who are in the Trotter Zoom room, I think it's great. And that makes me think of how we can do that in the future. Really excited about today's presentation. One thing, I don't know how many of y'all noticed, but I was immediately impressed with the font on this presentation, as well as all of the colorful characters. So sometimes we're on the Zoom and some of you may just even be on your phone for all I know, but it's hard to read. And I think that this really was helpful for us to be able to follow. So thank you so much to Dr. Verma and her assistant for making that happen. Appreciate that. It's a wonderful relationship that we have had through 2022 with UTHealth Houston Neuroscience, and hoping to continue that in the future. So again, as Elise mentioned, if you have any more questions, please reach out to her. I will be sending a recording to everybody. And thank you so much for being here. I hope everybody has a wonderful holiday and enjoys the rest of 2022. Thank you so much.
Thank you.